Thank you for joining us on the latest episode of the Jones Point Navigator series, where we bring together policy experts and innovative companies to talk about interesting issues at the intersection of policy, markets, and healthcare. Today, we're thrilled to be joined by Miranda Franco of Holland and Dave Rawlins of MyndVR to talk about the policy and market outlook for digital health and the VR spaces in healthcare. Taking a giant step back, it's been a pretty active couple of months in the digital health space. On the positive side of the ledger, you've seen more digital health therapies being added to commercial payer formularies, and certainly some positive news from AMA and CMS on the coding side. Of course, on the negative side of the ledger, you've seen the recent bankruptcy from Payer, which certainly is challenging when a high-profile industry leader faces challenges. So in an effort to understand kind of where the industry is headed and some of the impacts of the recent developments on the industry, I think it's important to start with the regulatory outlook and the policy background for this emerging sector. And then we can talk a bit about how that's impacting decisions in the real world and how companies are approaching this. So with that, I'd love to turn it over to Miranda Franco from Holland & Knight. Miranda, why don't you start giving a bit of your background and your practice area at Holland & Knight, and then we can delve into some of the specifics here.
Sure. Thanks so much, Tommy, for having me. Miranda Franco. I'm a senior policy advisor here at Holland & Knight. I have been with the firm for, just over a decade. I have a pretty broad portfolio, but for the purposes of this conversation, I do a lot with CMS on coding and reimbursement and a lot in the digital health space. So as you mentioned, following a lot of these recent transactions with CMS as it relates to prescription digital therapeutics and virtual reality. So very excited about our conversation today.
Great. And we'll just get into it. So I think the genesis for this call was the recent CMS decision to give a HCPCS code for virtual reality therapies. So would love to start with just, an overview of what they decided and what it means for those of us who aren't totally steeped in HCPCS and DME.
Sure. Well, just to back up a bit, and you sort of intimated this in your opening, but digital transformation in healthcare has accelerated the use of technologies like virtual reality in order to solve some major problems that exist in healthcare delivery. So for substance abuse disorders, for mental health challenges, for chronic pain. However, like many facets of healthcare, there are perennial challenges keeping coverage determinations at pace with innovation. This is unfortunately not something new or unique to digital therapy we see in many other facets of healthcare. And until recently, the pathway for billing and reimbursement for digital therapies has largely been characterized by unique sort of ad hoc contracts between manufacturers and payers, and I'm sure Dave can touch on some of his experience there. And pharmacy benefit managers have established some digital health formularies in the last few years to cover software as a product as a pharmacy benefit. But this has really been a piecemeal approach. And so we've seen Congress take some efforts I think we'll touch on in a bit, but really, as you mentioned, what's been sort of the most trailblazing endeavor in this space as of late has been that CMS has taken their statutory authority in a coding and benefit category determination and creating a unique HCPCS code, a level 2 code to describe Relieve VRX, which was granted FDA approval back in 2021 through breakthrough status, I believe. And so that's an immersive VR medical device for home use that is indicated for treatment of lower back pain. And it's only available by prescription, and a patient takes it during a finite period of time. But what's very significant here is that this is the first benefit category determination that CMS has advanced under the durable medical equipment and prosthetics and orthotics and supplies, the DME benefit category. And it's the first to also receive, as I mentioned, the HCPCS code. So while CMS did not mandate coverage or specific payment, that's still up to the Medicare audit contractors on a claim-by-claim basis. This does indicate that there is, I think, significant interest by CMS to expand coverage under existing benefit categories. So this is a big game changer. It certainly doesn't mean that there's not issues to overcome, but I hope it means that we are moving forward in this space, and it will help bring, and I believe there are 36 digital therapeutics that have been approved by the FDA. And so I hope that will move this process forward because, as we all know, approval does not mean coverage or payment. So that's what's been lagging. And so this will hopefully show some headwinds into progress in this area.
No, that's great. And that's a very succinct summary of a very complicated issue. So thank you. And I think we will come back to kind of the FDA CMS interplay a bit later. So just really quickly back to this coding decision. So let's talk about some next steps here. So, for Relieve, they've got this. So what are the kind of next steps on payment? Is it, you said claim by claim? Is there an NCD, something that might be a next step here? Would love to kind of go through the next steps and the timing around those things.
Yeah, so as I mentioned, CMS did not mandate coverage. So this now goes to what's known as either the LCD, the local coverage determination, or national coverage determination process. I believe this will probably be or begin at the LCD level, which can be a bit arduous because there are multiple MACs and they can all levy different determinations and they cover different geographic areas. So it's still a bit of a piecemeal approach. But usually if one MAC advances coverage, most of the other MACs follow. So that's the good news here. If they can advance a national coverage determination, that would be blanket coverage. And so that would be a much easier approach. But given what CMS sort of indicated in their response, I do think we're going to see this at the LCD level to start, unless we do see Congress intervene. And I know we'll touch on that. And that's another approach to address this in a more broad, sweeping way.
Oh, perfect. Thank you. And with that, let us turn to Congress. Obviously, there are it is late May when we're recording this, and there's a very important June debt limit deadline that most folks are focused on. But for the purposes of this call, the digital therapeutics legislation has been something that the industry's pushed for a number of years, and Pear obviously being a leader there. It's been interesting to see how the advocacy has actually pivoted a bit in light of the bankruptcy, to talk about why we need additional, Congress to step in and provide additional authorities here. But would love, again, to start with, your view of what the legislation is, what it would do, and the more complicated question, outlook and timing.
Yeah, so as you mentioned, the Access to Prescription Digital Therapeutics Act is not new. It's been reintroduced this session. It was introduced in advance of what happened, unfortunately, to Pear, but it did not pass. So it's been reintroduced this session. On the House side, it's being led by Mike Thompson from California, who leads the Congressional Telehealth Caucus and does a lot in the digital health space, and Kevin Hern from Oklahoma. On the Republican side, there's a Senate companion bill that's led by Senator Jeanine Shaheen of New Hampshire, and then Capito from West Virginia. So this bill, I think, is a response, again, to that piecemeal approach that we have seen. As I mentioned, there's sort of been an ad hoc effort by manufacturers to date, and this CMS decision, yet it's still not the perfect answer to coverage. So what this would do is provide a benefit category, a Medicare benefit category. And I should note that this is not new. Congress has done this before. We've seen it for mammography screening. We've seen it for home infusion therapy, to name a few areas where Congress has legislated benefit categories. So that is the intent of this bill, is to have a kind of a clear coverage pathway and sort of move CMS along, since they haven't used the full prowess of their statutory authority to do this on their own. And so as I understand, sort of the big barrier at the moment in terms of movement is garnering a Congressional Budget Office score. And so the sponsors that I mentioned are sort of working feverishly to get a score of the bill so this can move forward. We're seeing there's a hearing right now, and there's been several this week, that bills that don't have a CBO score or have not received technical assistance from the agencies are having a hard time moving forward. So I think they want to get that all together, and then hopefully we can see some forward progress here. But it is a bipartisan effort. We're seeing more and more folks come on. So I think there's some real promise here. There's also, and we can touch on this too, but I think that's the most significant piece of legislation in this space. But there's also something called the Ensuring Patient Access to Critical Breakthrough Products Act that I just want to flag, and that would provide instant Medicare coverage upon FDA approval for 4 years. This follows a rule that was rescinded that I think we'll touch on in a bit as well. But so that's another legislative effort that doesn't solve the problem that we're facing, long term, but would provide that sort of 4-year window to approval. So it's another avenue that Congress is exploring.
No, thanks for that. And I think, actually, so one quick question there. Obviously, when bills get introduced at the start of a new Congress, or any kind of noteworthy changes to this legislation when it's reintroduced, or is the industry pretty happy with where it was? I know sometimes feedback in previous Congresses can shape and improve the chances in future Congresses. So just curious there.
Yeah, I believe that the language is mostly what was introduced the previous session. I think the only efforts, and this is somewhat distinct from the bill, but I think there was a congressional effort sort of that was complementary to this bill to try to drive some state Medicaid director guidance on the Medicaid side around this. And so I think a lot of the bill sponsors were engaged in an effort to that end. At the end of last year, there was a hope that they could move this bill in the omnibus last year. That did not come to fruition. So all that to be said, that there was a lot of momentum at the end of last year that I think is carrying through into this year to really move this forward. And unfortunately, as you mentioned, PAIR and sort of the demise that happened there, I think will also create some continued fervor around moving this along, because now we've seen what can happen if legislation like this does not advance, and it's to the detriment of patients.
No, that's great. And thanks for that. And I think from an optimistic perspective, it certainly seems like, outside of this area in healthcare, it's been a very active year, with energy and commerce and help and ways and means, all talking about moving, we'll call it relatively small ball pieces of legislation. So I think, like, as we all know, anything in Congress, you need a vehicle. And it does seem like there'll be some things at the end of the year, should the ability to get a score and a pay for if necessary, because I think a lot of folks have been pleasantly surprised with the amount of activity we're seeing in Congress and bipartisan, really, especially in the services side of things. So given this backdrop, I want to bring Dave in here to talk a bit about how the policy environment's, impacting companies in the space. So again, happy to be joined by Dave Rawlins of MyndVR. Dave, would love for you to give some background on what you're doing, what the company's doing, and then we can delve into some of the specifics there.
Sure. David Rawlins, I'm COO of MyndVR. We're the leading VR-based digital therapeutics platform focused specifically on elderly care and senior care. So we have a platform of VR content that kind of spans an acuity spectrum, everything from social, emotional, recreational, entertainment content, up to some rehab-specific applications used in conjunction with therapy. And then we also have a number of applications which we're putting through product development that we would plan to put through the FDA pathway. And that sort of gets into this decision tree of how much resources we're going to put into that versus some of our over-the-counter type of therapeutic applications. Our model, as it is today, is primarily a B2B model. So we're selling our solution today and commercializing it essentially as an over-the-counter product to a range of facility operators, including senior living operators, retirement communities, memory care facilities, hospice, home health, and some veterans affairs clinics. My background, I spent a lot of my career in finance and actually investing in digital health companies. And then I also ran a pharmacy automation company where we were also involved in kind of pushing forward new legislation and regulation around the advent of automated drug dispensing kiosks. So I've had a bit of a background in trying to push regulation and innovation in healthcare forward, and it's a painful process, but one you have to navigate.
No, for sure, and certainly in an area like this where you and your other kind of competitors are really breaking new ground in potentially new ways to treat a whole host of ailments, it is an uphill push, but certainly worthwhile. So Dave, Miranda talked about some of the challenges from a Medicare reimbursement perspective. How is that impacting the industry and some of the to your point about the decision tree to go, I guess, B2B versus trying to go through the what we would argue traditionally in a medical device of going through kind of FDA to CMS. Like what has the past kind of 6 months to a year from a reimbursement perspective in DC meant for you guys and for the sector?
Yeah, no, it's a good question. I think timing is often key with these types of strategic decisions that you're making, and for us, we're focused exclusively on senior care, so that kind of focuses the mind a little, because you have no options but to really think about Medicare as your potential end market. And I think, look, if we'd been talking even 2-3 years ago, we would have almost certainly been exclusively talking about pushing our products through the software as a medical device pathway, looking for marketing clearance, and then hoping we would get coverage and payment and reimbursement off the back end of that. And I think what we've seen from the industry and some of the pain that's being felt in the industry is that you can spend a lot of money trying to do that with very little guarantee at all that even if you get through those hoops, you'll have a business model that's sustainable on the back end. And so that certainly changes, the decisions that you make. And like any business, we're really looking at the various different pathways and making, risk return type decisions. So when, the data inputs change, which they have done recently, you have to change your algorithm about where you're going to focus. And so, we look at the landscape really with kind of 4 different options. Number one being the over-the-counter option, which is a very viable option. And yes, you have to talk and lend, words like wellness and mental health rather than using specific health indication claims. But you can still do that. You can still build a very viable business that can impact the lives of millions of seniors, and we're doing that. I think the second option is to look for funding strategies through things like the CNP grants, through things like NIH. And that's very valid and very helpful. And it certainly helps companies like us get our foot on the map. But again, it's not a sustainable revenue source. So it's not something that we would necessarily bet the business on. Then you have Medicare Advantage, which we can talk a lot more about because that is something that we are very optimistic about. And we're very proud to say we're the first VR company that has been approved as a supplemental benefit for Medicare Advantage. And so we see that as a real avenue and a real business for us. The fourth bucket is third-party billing options. So, you have groups that have billing. There are codes out there today. And essentially you're saying, well, we're going to build tools that those service providers can use and they will bill. And, as a tool, we can produce products and we can produce things that we know have efficacy, but ultimately the burden is on them to bill and actually, use the product. And then the final category is direct billing, where, really that's where the jury is out as to how real that is as a pathway. I think traditionally we would have looked at software as medical device and the pharmacy benefit as being probably the most likely area. But with the rule, most recently, and the topic of DME being kind of brought forward, it's a very real prospect for us, particularly with VR, where you have the headset, which is almost by definition putting you into the camp of a piece of equipment and effectively a durable piece of equipment, because we know the lifetime is at least 3 years of those products. So that puts us into that camp and really does actually create a real pathway that we're talking about and thinking about. And we're very excited about what Applied was able to do with that. And we think that may be a really valid pathway for us as well.
That's great, Dave, and you covered a lot of ground. So actually, just quickly on the last point, Miranda, I just want to pull you back in here. So, and apologies for my not knowing. So the HCPCS code, is that specific to that company, or is it something that everyone can use?
The HCPCS code it's E1905, specific to the service that Relieve provides. So technically, if another VR company came in and was providing the same sort of lower back pain, it could follow, but it's not a broad coding that would cover all of VR in this space.
So in a hypothetical where Mind has a back pain solution, Dave, you guys could bill with this code, correct? It's not specific to them, right?
That it's a good question, and I think there's some controversy here, because I think we initially read the ruling as it being specific to Applied, but I've actually subsequently seen quotes from Applied themselves saying that the classification is more broad and it applies to defined as VR as a cognitive behavioral therapy that includes pre-programmed therapy software. So the software could be different and could potentially come under the same classification. But I mean, this is new and we're still trying to navigate what that exactly means. I think the bigger thing for me is that when you looked at how they've defined the classification, it's a whole new category. And right now they are the only code in that category. I mean, when you look at the list, there's, most of the other HCPCS codes, they have, thousands within that category. It will go from, E109 to E209. But in the case of Applied, there's one. And I think the theory, at least that we're sort of looking at, is that there's the hope that is a new category that we can add more codes to as we go. But I think the other factor is that clearly CMS, and if you read the actual letter that they wrote with the approval, with the code, that it actually it shows that there is optimism around having VR and digital therapeutics included in this, and that's what we're really excited about. Is there's clearly a window here, and they're trying to allow other companies potentially like us to come in behind and be the second mouse that gets the cheese.
And I would just, I'm so sorry. I would just layer on, because I'm now pulling up the coding decision. And so it says specifically virtual reality cognitive behavioral therapy device, including pre-programmed therapy software. It does say to describe Relieve VRX. So I think there, to Dave's point, there's some wiggle room there, right? So they certainly did frame this to describe Relieve VRX, but the actual the code in itself, I think others could follow, and or at least could make an argument to follow if they were in that same behavioral therapy space.
No, great. Thank you, Miranda, for the real-time analysis. That's fantastic. So Dave, just back to you for a second. You made a comment about the supplemental benefits in Medicare Advantage, and as everyone knows, Medicare Advantage is big and growing. I think if we're not at 50% of seniors yet, we'll get there soon. Just talk a bit about that as a strategic decision, because certainly, to your point, you're focusing on the senior population, so that the focus is helpful there. And if 50% of the population is in MA, would love to talk about your thoughts on pursuing that as a strategic priority.
Yeah, sure. So, I think the first point to make is, as you said, MA is massive, right? It's massive and it's growing, and it's also very crowded in that respect. There are, thousands and thousands of vendors all trying to go after that same PMPM amount and all trying to make a claim that they can, improve, whether it's enrollment, MLR, or star ratings. There's a lot of companies doing it. And I think you can get lost very quickly if you try and go after kind of MA more broadly. I think for us, where we found some real product market, fit is around iSNP and SNP plans specifically. iSNP in particular is a very kind of interesting area for us, because by definition, all the patients who are members of an iSNP plan are institutional long-term care patients. And so for our product, where we're focused on those types of patients, it's a great fit. And what I think is really great about MA and the way it's designed is it deliberately gives plans latitude to differentiate themselves, bring other products and services onto their benefit. And that essentially gives them a route to try things. Now, you don't try, you don't get anywhere without iteration. And I think that's kind of one of the things that we always have to think about in healthcare is how do you iterate whilst keeping patient safety in mind? Because the classic tech mandate of fail fast and cheap, that doesn't work in healthcare. You can't fail when people's lives are on the line. But what you certainly can do is you can take products and services where the risk profile is low enough that that you're not going to cause them harm, and you can trial things in a supplemental benefit way. And CMS has a pathway that allows them to review supplemental benefits and approve them through this basis. And that's what they've done with us. And so we're really excited about this. It's the first year we have been approved as a supplemental benefit. And so far what we're seeing is that it can be very effective for a number of different things. Obviously, patient enrollment is one aspect to it. And clearly a VR headset that offers people the chance to travel to Paris and see The Lion King has an attractive element as a enrollment tool. But the other and perhaps more important thing for us is that it's providing us a platform to prove out the things that we think are true, which is that we can have a real impact on the health of these seniors with the more therapeutic modules that we have on the platform. And what we found so far is that the partners that we're talking to are very interested in both of those sides of things.
That's great to hear. And one more for you, Dave, and then we can kind of move on to some other topics. You mentioned the VA, and I know the VA has been in the news on some other issues, given the confusing coverage over the some of the Alzheimer's therapies. But I think for early stage companies, the VA seems like a very good partner to work with. I'd love to talk, kind of high level about your experiences with them. Certainly, there's applications there, for the veterans population, and I think probably on the more therapeutic end as well. But would love to talk about, what your experience has been with them and kind of lessons learned and advice for folks who are thinking about it.
Yeah, you're absolutely right. And I think, hats off to the VA, because they really have put themselves out in front as a thought leader and as an innovator, which is, not often what you would think about a government institution like that, but they really have. And part of the way they've been able to do that is because of the way that they're set up. There is pockets of funding that is explicitly earmarked for innovative projects. And then rather than managing that at a kind of high level, they allow that to be basically distributed down to the vision level, where decisions can be made and applications and products can be tried and piloted at that vision level, but with real dollars behind it and with a pathway to potentially land and expand within the VA. So we've had nothing but, a great experience with them. And not only have they, tried our products and are using our products and are growing the use of our products within the VA, but they've also helped us with research. And they're happy to publish research. They're happy to talk about research at conferences, which again, for a relatively early stage company like us, is massive to have, the backing and the validation of the VA with data. So they've been a great partner. I think, in terms of learning lessons and things that we would say for other companies, I think one of the things that you do have to be kind of mindful of is how you actually get into that flow of funds. And there are third-party contractors, VA contractors, that you have to work with and you have to assign yourself with, who are bidding on these specific contracts and these RFPs. And so you have to choose those very wisely because, frankly, they're not all equal. And some are better at bidding on things than others. And you can easily find yourself in a position where you partnered with a group that may not be successful in their bid process, and you're left out, even if your product is superior. And so that would be the only thing that I would say. And so, but putting that aside, veterans has been a fantastic channel for us.
No, I think your point's well taken, because certainly a lot of the public press around the VA has to do with, kind of wait lines and access to service. But the innovative side of it is something that I think, probably is still underappreciated. And it's great to hear. It's been such a great partnership for you guys. So I'm transitioning a bit, Miranda, back to something you mentioned on the, coverage with FDA approval. Would love for you to talk about that legislation, but also kind of the backstory there, right? The end of the Trump administration, they finalized the MSIT rule, and it looks like the Biden administration will be coming out with the TSET rule, is I guess what we're calling it. Unless it came out in the last 30 minutes, we can still speculate on what's in it. But would love, kind of to go high level from you on what that would do, what it might mean, your expectations from the Biden folks, and then Dave kind of talk about some of the real world implications if that actually is finalized as contemplated.
Sure. So there's sort of three buckets as I see it. There's what CMS can do under their authority, and they've made some headway to that end. There's what Congress can do. And then there's this regulatory rule that could potentially be a game changer. And so, as you mentioned, the Medicare coverage of innovative technology MSIT rule was pulled back in 2021. We are awaiting its release. We're hoping it was going to be released before we convene today, but unfortunately, no such luck. But as I understand, it's being revamped and release is imminent. So this was initially introduced under the Trump administration. It would have automatically provided 4 years of Medicare coverage for devices that receive FDA breakthrough device designation. That is in part to address that LCD issue that we talked about. So there's a lag from FDA approval to coverage determination. So for an NCD, a national coverage determination, that can be a year or more. For LCDs, that, as I mentioned, that coverage can be inconsistent based on geographic areas and can even take longer potentially. So the rule was an effort to sort of address that lag in coverage. There were some concerns around evidence standards for devices that were previously awarded breakthrough device designation. And so because of that, the rule was repealed at the end of 2021. CMS at that time said that they needed to look at the kinds of clinical studies that were needed, and that FDA authorization might not consider sort of differences in clinical profiles and some complexities of medical conditions and things of that nature. I do think the big thing here to note, though, is that the rule, as it was previously written, prohibited breakthrough designated devices without an existing Part A or Part B benefit category from receiving automatic coverage. So as you know, the new digital therapeutics, as we've been talking, are relatively new and don't fall under an existing Medicare benefit category, with the exception of what just happened with the DME. They would have been excluded from coverage under this rule. So it actually wouldn't have been terribly helpful for virtual reality for existence. However, the rule is being revamped, as you mentioned, and there has been a huge push. I think 6 members of Congress in the House have urged CMS to reinstate the rule with modifications, and one of those could be addressing this existing issue from the previous rule that would have prevented virtual reality from that 4 years of coverage. And so we're hoping to see a new rule that addresses some of those evidentiary standards that I mentioned that CMS was concerned about, but also providing coverage for digital therapeutics that were not covered under the previous iteration of this. And that's where I had mentioned the Ensuring Access to Critical Breakthrough Products Act. So that is a piece of legislation that would provide instant Medicare coverage upon FDA clearance for 4 years. And that's, again, to try to get to the fact that the rule was rescinded and they wanted to move something forward. So that might be unnecessary legislation when we see the new rule, if it does address these issues, but we're all sort of waiting with bated breath to see what this will mean for the sector, certainly.
Yep. Thanks so much. And just a point of like technical clarification. So when a rule is pulled back, when they come out with this new iteration, is that a proposed rule, or would it be a final version of the previous administration's rule?
I guess theoretically they could do it interim final, but I would be very surprised. I would assume this would come out as a proposed rule, especially since we're under new administration. Not allowing ample time for comment and notice is something that can see court time. So I think everyone wants to avoid that. So I'm going to assume we'll see this in proposed fashion, and then allowing a 60 to 90-day window for comment, and then see a final rule move forward.
And then, so let's say, just for sake of argument, rules finalized by the end of the year, just to keep things simple. Practical kind of real world implications is does it go live then Jan 1, 2024, or is there some kind of phase in, or industry will have to take some time to kind of put together necessary applications to use this pathway? Kind of talk about the both practical and real world implications of if and how this is executed.
Yeah, I mean, I could see them very, very much making this as of January 1, 2024, if the rule comes out here, shortly, and then providing enough time again for window of comment and then finalization. They could also do a glide path. That's something we've certainly seen, where it's an implementation over the course of a few years to move this along. But given all of the political pressure, I really wouldn't be surprised to see sort of a finite date that's set for approval. So that could be January 1. If the proposed rule continues to slide, we don't see it for a few more months, it could be July of 2024 as well. Gotcha.
So Dave, back to you. So let's assume, and we'll be very optimistic with our crystal ball here, that the most expansive version that Miranda described is finalized, allowing for VR to take advantage of this pathway. You talked a bit about that decision tree. Is this a game changer from the decision tree perspective, or just kind of a nice to have and a nice option in the toolbox as you think about rolling things out to market?
Yeah, I mean, potentially it could be. I mean, I think that the issue is that in the rule, how it was kind of initially written, to a great extent, digital health was excluded, right? So it's not something we've put a huge amount of attention on because of that exclusion. But the addition of this, basically bringing digital health into that would potentially change the game for us. And I think 4 years is a very long period of time, and it's certainly long enough for us to be able to, prove our worth and then actually get kind of coverage not only with commercial players, but actually then have the data to show that this is working and kind of have a sustainable business on the back end. So I think it would change the game. What I've kind of learned though is that anything where there is the potential increase in spending, which this would likely be, you have to materially kind of discount the probability that ends up happening in the form that you would like it to happen. And so whilst I am hopeful, I am far from optimistic.
That's a very good perspective. I appreciate that. But just back on kind of the FDA side of things, I think, you mentioned that it's, can be very timely and expensive to put together the necessary data for an FDA submission. Again, with the caveat that the 4 years would be fantastic. Does that change your decision about devoting the resources to that, or is it just because how does that really affect that?
It does, and I mean, I don't want to also completely dismiss FDA as the pathway, because that's clearly something we have aspirations to do. And particularly now that there have been precedents, it makes life a lot easier. And I think that is something that does work within the FDA pathway very well. That the pathway itself is not the issue; it's the post pathway that's the issue. In that you don't have any real assurance that you're going to have a revenue stream afterwards because of the coverage decisions and the payer basically network thereafter. So it's not necessarily the pathway that's the problem. And so this would to a certain extent solve that, because it would guarantee you payment afterwards. And I think for us, what has been really helpful about the last 4 years is that we have had a large number of companies go through the pathway and have created precedent for us. So we can come in, we don't necessarily need to have de novo or breakthrough. We can have a precedent and come in behind and get clearance, which is something that we're certainly looking to do. And I think obviously in that light, we also have to sort of talk about our business being very different to a lot of other different businesses. We don't have a point solution in the same way that some of these other groups do. So we're not betting the farm on one specific product. We have a platform of products. So what we're now looking at is, right, of the platform of products, which ones do we think offer us the best chance to ultimately, a reimbursed revenue stream? And so in some cases, the sad truth is you're now looking at products where you have early effectiveness data, but it would have to be through a de novo pathway. And you're balancing that against another product that you may have where you have a precedent already in place and the pathway is going to be easier. And you're saying to yourself, well, let's put more resources behind the latter because it's an easier pathway for us to go through. So, but those are the types of decisions that you're making. I mean, in an ideal world, you would fund all of these and you would make sure that all of them get through to market because we know that they're going to have, a great impact on the lives of seniors, but that's just not reality.
No, that's well said. And Miranda, back to you real quick, and then I'll have one wrap up question. If again with the crystal ball, if we look, a year out, what do you think is more likely to have happened? This more expansive version of this rule, or the enactment of the PDT legislation? It's a tough one, I know.
That is a great question. I think we'll see more headway coming on the regulatory side than probably the legislative, simply because there are, as you mentioned at the onset, there's the debt ceiling. There are a number of sort of must pass items that have to be addressed by September. And we're working through a very challenging Congress in terms of sort of partisan approaches. So that's not to say that I don't think that this is something that's not being prioritized by many members, but I think in the immediate future, we'll see more movement happening on the CMS side. And again, I do think the fact that even though it is somewhat piecemeal in terms of coverage, what happened with CMS is not insignificant and should be underscored in that I really do think that sort of breaking down the barn door, it may not seem like it, but from someone who does an enormous amount of work with CMS, it's quite significant. So I do think we'll see more traction probably happening there more quickly than we will on the legislative side.
No, that's great. And thank you for bringing us back to the genesis of this call, because I don't want to overshadow that. So the last question here, there are active rumors that Apple will be coming out with the VR headset, at their upcoming developers conference. So, a couple of things. One, Dave, would love your kind of market views on if, a very large consumer products company comes out with something, what it means for the space. And then Miranda, would love your take after that on what it means from a DC perspective when Apple, kind of engages on something. I know that's a tricky one as well, but first we'll start with you, Dave, on what it might mean for, kind of broad adoption of the stuff that you guys are working on.
Yeah, no, it's a great question, and one that we have to be a little careful talking about around. But what I can certainly talk about is what the press is talking about and what the market is talking about. And I think what's very interesting about it is that the market and the press have a sort of all or nothing approach with coverage with respect to any kind of technological innovation. The articles being written today are literally signaling the obituary of the metaverse and the death of VR. And I think that doesn't help anyone. It doesn't help fundraising. It doesn't help in terms of actually having discussions with Congress. And the reality is very, very different. The VR industry is growing very, very fast. It's a fantastic product, not only for kind of kids and first-person shooting up games, but for healthcare. And there's an enormous body of research, tens of thousands of studies done on VR in healthcare. And that train has left the station. That is something that we feel very strongly about. But when you have media coverage sort of signaling the end of the VR world, it doesn't help. And so having a company like Apple, that have such a phenomenal track record of bringing products to market, innovating, and really pushing things forward, is going to be a huge help to the industry. There's just no denying that. I think the reality of it though is where is this going to be priced? What is the actual capability of it? What's adoption going to look like? And I think on that topic, we're potentially a little bit more cautious, because I think that, as we've seen with a lot of product adoption curves, they don't all follow the route of the iPhone. And I think for us, we're looking at the industry, and particularly for senior care, with the view that more than likely to begin with, you're going to be still looking at a lot of the same types of hardware that we have today, because the Apple device is going to be likely focused more on a consumer audience and potentially a higher end audience. And so for us, the business versus the kind of the narrative are two different things. We are a hardware agnostic company in the sense that we want to have multiple different options for hardware for our end users. And so having Apple as an option is going to be phenomenal. And so we're very, very optimistic, but we shall see.
Exactly. No, and I think I'm glad you made the point about the being hardware agnostic, because that was going to be one of my follow-ups. But I think you're right. I think it's challenging, right? Because you do have, quote unquote, death of the metaverse, but then you've got a number of articles, at least in the DC trade press, about how loneliness is an important public health issue coming out of the pandemic. And I think if you think about what you guys are doing and the senior care space, like that is a big solve for a big issue. So yes, you're right that you have to be careful with the media narratives, but but again, having a large company like Apple, and given their expertise in bringing things to market and really kind of changing the game, I'm hopeful that it's helpful for kind of all stripes of the VR. And then Miranda, just from you on a DC perspective, does it matter? Does it not? I know it's a tricky one because it kind of gets into the broader tech argument about tech industry in Washington, but would love your thoughts on what it might mean from a healthcare perspective.
Yeah, I mean, I'll agree with Dave in that it certainly can be a driver. I think even just forgoing coverage and an approval, I think just in generating consumer interest, patient interest, right? When you have a household name like that, that's engaging in this space, I think it certainly helps with the sort of desire and uptake. From a congressional standpoint, I'm going to presume that this might be viewed differently depending on your party affiliation in Congress. But I would note that anytime a big actor like Google or Apple or Uber sort of comes into the conversation in healthcare, it does sort of raise some eyebrows, right? We're in a moment where this week and last week, we have hearings about competition in the healthcare space and about consolidation and what that means when very big actors come in and sort of consume some of the smaller actors in the healthcare space. And what does that mean for driving innovation? What does that mean for sort of autonomy for smaller, folks in this space? And so I see it sort of in both lanes, and that there could be concern about an Apple coming in and just sort of taking it all over and having the entire market share and what that means. And so I could see Congress being concerned about that, certainly. But then there is they are a household name and what they can drive from an innovation standpoint. So I think it'll be a complex and broad conversation about what this means moving forward. And we've seen it. We've seen it with Uber, perhaps providing transportation for patients to hospitals. We've seen it with Google and their AI. So it's not necessarily a new conversation, but it's one that's burgeoning on the Hill, certainly.
Very good. Well, with that, thank you both for joining us. We really appreciate it. It's been an incredibly insightful conversation. I will make sure that folks get access to your contact information should they want to reach out and chat further on these. But with that, Dave and Miranda, thank you so much for your time, and look forward to keeping in touch.
Thank you so much.